Okay, well, some of you know me, some do not. My name is Anthony Fuller Jr. I'm a student physical therapist assistant. So that's Morgan Griggs over there. She's my clinical instructor. Some of you have met her as well. We're going to be talking about Parkinson's disease today. Before we start, does anybody either have Parkinson's or know someone that has it and they're willing to raise their hand? A lot of people. Okay. All right. So in this presentation, a couple things we're going to do. I'll talk about some basic facts of Parkinson's disease. We're going to define it, discuss some of the symptoms of it. We're going to talk about how it works specifically. So in that section, there's going to be a technical definition. We'll talk about pathways in the brain and a few things like that. When we get there, please don't panic. I'm going to try to explain and break it down as we go. And that way, when you guys see technical definitions in the future, you'll have a better idea of what it means. We're going to talk about some types of Parkinson's disease, some treatments for it. We'll discuss some exercises and therapy that we can do. And then I'll give you a home exercise program that you can take home with you, and that'll keep you in shape as time goes by. As we go, please feel free to raise your hand and ask a question. I'll try to answer them. My answer might be I don't know, but I'll do my best to give you an answer. So Parkinson's disease, and I'll just say PD for the most part, just to save time. So this is about 60,000 new cases per year in the US, roughly 1 million or more currently in this country, and roughly 6 million worldwide. In reality, the numbers are probably much higher than that, because a lot of people with Parkinson's disease are undiagnosed. But as you can see, it's fairly common even with what we do know. Most people are diagnosed after the age of 60. However, a lot of people do get a diagnosis before the age of 50. That's usually referred to as young onset Parkinson's disease. Classic example, Michael J. Fox. A lot of people know him. He was an actor in the 80s and 90s. He was diagnosed at the age of 29. No two Parkinson's patients are alike. This is a very important point. If you go to the doctor and they say, okay, you have Parkinson's, or someone that you know does, you might ask, okay, well, what can I expect in a year from now, or in 5 years from now, in 10 years from now? The problem is they don't know. I saw an expression, someone said, if you've met one patient with Parkinson's disease, you've met one patient with Parkinson's disease. It's a little different for everybody. It is not fatal, so that means that most Parkinson's patients have a normal lifespan. So let's get into the definition. And again, this is technical, but I'm going to break it down one piece at a time. Parkinson's disease is the progressive degeneration of the dopaminergic neurons within the substantia nigra, leading to altered motor movement, including tremors, rigidity, akinesia, bradykinesia, postural instability, and other symptoms. By the way, you got the video going, right? Okay, good. All right, so let's look at that one piece at a time, and we're going to start with the symptoms. So the way of remembering this that we have is the word trap. So think of the word trap. That stands for tremors, rigidity, akinesia or bradykinesia, and postural instability. Starting with tremors. So a resting tremor basically means when the patient is relaxed, like let's say the arm is relaxed at the side, it gets that little bit of shake in it. So that's a resting tremor. The other common sign that we see is called a pill rolling tremor. That's just what it sounds like. So picture rolling a pill around in your hands, moving your thumb over your fingers like that, but obviously there is no pill there and that's involuntary. So that's T for tremors. Rigidity, that basically means that the muscles are flexed and seized up and tight when they're not really supposed to be. So that presents in a couple different ways. One is lead pipe rigidity. Imagine your arm is like a lead pipe, and if you try to pull it away, it'll just snap back to where it was. That's lead pipe rigidity. Another common way that that manifests is called cogwheel rigidity. That's kind of an on-off thing. So if you pull on the arm, it'll release a little bit at a time, like a cogwheel. So we've got T for tremors, R for rigidity. A is for akinesia. What does that mean? Well, A means lack of something. Kinesia means movement. So akinesia means lack of movement. So Parkinson's patients, they have a difficulty initiating movement. Something like sitting up, standing up from a chair, beginning to walk, beginning to move. That also means that they have difficulty stopping movement. So if they're walking along and all of a sudden an obstacle comes out of nowhere, it's difficult to stop on a dime. So that's akinesia, it's lack of movement. That also leads to what we call a mask-like expression. So if you see a patient with Parkinson's and they look like they're angry at you, they're probably not. It's just that they can't move their facial muscles as well, just like the rest of the body. So that was akinesia. Bradykinesia. Brady means slow. Kinesia again means movement. Put together, bradykinesia means slow movement. So same thing we were talking about. They may be able to walk and move, but at kind of a slow pace, like they're moving through molasses. So we had T for tremors, R for rigidity, A for akinesia, and then lastly P is for postural instability. So you get kind of that hunched over posture, start to contract and get closed up like that. Patients have a struggle with staying balanced, staying upright. The risk of falls increases with time. And that leads to them kind of widening their feet out to feel more balanced. Whereas with a normal walking pattern, your feet stay more narrow. And that leads to what we call a Parkinson Gate. So you've probably seen that or experienced it, sort of hunched over and taking slow, shuffling steps so as to feel balanced and not fall over. So that was our trap, right? Tremors, rigidity, akinesia, postural instability. A few non-movement symptoms. I'm not going to go through the whole list, but difficulty with attention, planning, language or memory, fatigue, hallucinations, constipation, and interestingly, micrographia, which means small handwriting. So you see this person here, my name is John. He started with large letters, and then as he kept writing, they got smaller and smaller. That's a very common symptom, and it's actually one of the first symptoms that gets noticed that leads to a Parkinson's diagnosis. And I guess I should talk about that for another second. One mechanism of Parkinson's is that patients will do small movements, but perceive them to be normal size. We'll talk about that more as we go, but that's what leads to the small handwriting. So far, so good? Any questions? Good. Okay. So let's talk about how this actually works and what causes it in the brain. So the mechanism for the akinesia, the bradykinesia, and the postural instability. Going back to our definition, we've talked about the part in red, that's the symptoms. Let's talk about Parkinson's disease is the progressive degeneration of the dopaminergic neurons within the substantia nigra. What is that? The substantia nigra is a part of the brain. It's right smack in the center of it, as you can see from the cross-section. Substantia nigra literally means the black substance. So it's that kind of dark ring that you see right there. What it's responsible for is producing a chemical called dopamine. Dopamine is a neurotransmitter. So it's a chemical inside the brain, and it has several different jobs. The main thing that people know dopamine for is a feeling of reward or incentive. So let's say you go to work, you do a good job, you get a nice big cash bonus, and you feel really warm and fuzzy and good inside. That's dopamine being released in your brain. We also get it when we eat a food that we like, or if we have sex, anything like that. We're interested in that. Dopamine also plays a role in movement, which is what we're primarily interested in today, but we will talk about the other things. Inside your brain, there are two pathways. There's what we call a direct pathway, for if you're trying to initiate a movement. So let's say I want to flex my bicep here. There's a direct pathway that I can use to tell my body to do that. Then there's also an indirect pathway in the brain that relaxes muscles, okay? So those two kind of work against each other. Interestingly, both pathways are active inside the brain for every muscle all the time. So the way I think about that is picture you've got a hot and a cold faucet on your sink. And both the hot, that represents the movement, and the cold, that's the relaxation. Both of those are going at once all the time. Well, what do you get if you've got the hot and the cold going at the same time? It's kind of lukewarm. It's really neither hot nor cold, right? If you want to get hot water, what are you going to do? You're going to turn the heat up. You're going to turn the cold down, right? That gives you hot water. That's what dopamine does. It turns up the heat. It turns down the cold. Dopamine helps you to increase the contraction and decrease the relaxation. And that allows you to create strong, powerful, controlled, rapid movements. So far, so good. With Parkinson's, what's happening is the neurons inside the substantia nigra, that's the part that we talked about, it's in the midbrain, they start to degenerate. They start to fall apart and get old and decay. And so because of that, they can't release as much dopamine. So, degenerated dopaminergic neurons, that means the neurons that produce dopamine, in the substantia nigra. That leads to that decreased dopamine release. Since dopamine is responsible for increasing movement, making the movements big and powerful and strong, less dopamine means that you can't do that, right? So you can't initiate movement. And that's what leads to the akinesia, that's the lack of movement, the bradykinesia, the slow movement, and the postural instability. So those symptoms that we talked about, kind of the contracted, slow, difficulty getting going, that's all because of a lack of dopamine. Any questions so far? Okay. Let's talk about the tremors and the rigidity. This works a little bit differently. Acetylcholine. This is another one of those neurotransmitters that we talked about, much like dopamine. Acetylcholine moves through the body, and its job is to stimulate the neurons that are responsible for movement throughout your arms and your legs and your body. Every chemical that you have inside your brain or inside your body has what we call an antagonist. It means it's a chemical that does the opposite thing, and that's how your brain controls your body. In the case of acetylcholine, that's ACH, guess what its antagonist is? Dopamine. So in a normal brain, you can see you've got this balance on the seesaw, right? You've got enough dopamine to be an antagonist for the ACH, and enough ACH to be the antagonist for the dopamine. Balance. But as we already talked about, with a patient with Parkinson's disease, there's not enough dopamine. And so what that means is the ACH, the acetylcholine, gets out of control. So, because the acetylcholine stimulates motor neurons, without the dopamine to counterbalance it, the acetylcholine gets out of control. And that's what causes the tremors, right? And the rigidity. That's the too much flexion, the too much contraction. So, unfortunately, in Parkinson's, you've kind of got it working against you in both ways. The lack of dopamine is making it difficult to initiate the big, powerful movements, and the excess of acetylcholine is causing the tremors, the uncontrolled, the unnecessary movements. So far, so good? All right. So, we should have covered every part of the definition now. Parkinson's disease is the progressive degeneration of the dopaminergic neurons within the substantia nigra, leading to altered motor movement, including tremors, rigidity, akinesia, bradykinesia, postural instability, and other symptoms. So is everybody clear on every part of that? Yeah? A little overwhelming. Okay. Was there any specific part that you needed help with? Okay. If you do think of anything, just let me know and I'll try to go over it again. So let's talk about some types and some causes of Parkinson's disease. So you might hear people throw around a term once in a while called Parkinsonism, and that's just confusing. Because unfortunately, Parkinsonism can refer to either true Parkinson's disease, which is what we've been talking about, or it could refer to a bunch of other conditions and symptoms that are just similar to it, that mimic Parkinson's. And why is it called that? Because doctors are really bad at naming things. So it's just kind of confusing. With primary Parkinson's, or true Parkinson's, it is idiopathic. That means there's no known cause for it. So if you were to ask, what causes this, why does this happen? Nobody knows. It just happens on its own. Some risk factors are if you have a family member that has Parkinson's, that does increase your chance a little bit, or if you've been exposed to a lot of DDT, if you're a farmer in a past life, that can increase your chances as well. However, the vast majority of people with Parkinson's, it just happens, no one knows why. It typically affects the two sides of the body unequally, so one side is worse than the other, and it does respond to the medication, which is typically Levodopa. Okay, 1 second, I'm going to take a sip of water. Okay. With what we call atypical Parkinsonisms, these are anything that cause the symptoms of Parkinson's without actually being primary Parkinson's disease. We're typically able to tell that because it doesn't respond to the medication. So let's say you're a doctor and you're not sure if it's true Parkinson's or just something else. They might prescribe you Levodopa and then see if that works. And if it doesn't, you know that it's atypical. This also typically affects both sides of the body equally. So just a couple examples of this. You can have drug-induced Parkinsonisms. So if you're taking like an antipsychotic or an antidepressant medication, that can cause the symptoms of PD, without it actually being Parkinson's disease. The nice thing about that is symptoms usually go away when the medication is discontinued. So that's a pretty easy fix. Another common one is called dementia with Lewy bodies. So the way I think about this is, picture how plaque can build up on your teeth. The same thing can happen inside your brain. So that's what the Lewy bodies are. If that happens in the substantia nigra, that can cause that same degeneration like what we talked about, and that can mimic Parkinson's, even though it's actually a different condition. Any questions so far?
Is Lewy the doctor that described that?
That's a great question. Probably. I don't know. Yeah, the Lewy bodies are just a little buildup of protein. The thing about that disease is it can also build up in other parts of the brain. So it can cause like symptoms of Alzheimer's or other types of dementia, as well as Parkinson's. So that's why it's distinguished as a different condition. That'd be a good question to look up. All right, so some treatments. My first thought would be if lack of dopamine is the problem, well, maybe we can just put dopamine into a tablet and have the person take it and problem solved, right? The problem is that doesn't work. It'd be nice if it did. We've got this thing around our brain called the blood-brain barrier, and that lets some chemicals from the bloodstream into the brain and others it doesn't let in. It just so happens that dopamine is one of the things that can't get past the blood-brain barrier. So that doesn't work. However, a chemical called L-Dopa can. So what we do is we put L-Dopa into a tablet, and we call that medication Levodopa. We give that to the patient, they digest it, goes into the bloodstream, up into the brain, past the blood-brain barrier, and then the brain takes the L-Dopa and turns it into dopamine. So that does work. Of course, nothing is easy. You've got these enzymes in your body that take the L-Dopa and they try to synthesize it into dopamine before it gets to the brain. Well, as we already talked about, dopamine can't get passed into the brain, so it doesn't work. We combine that with a medication called Carbidopa. So Levodopa plus Carbidopa, you can see it right there on the box. The Carbidopa allows the L-Dopa to get past the blood-brain barrier and into the brain. So far, so good?
Does everybody probably not need the combination, or some people just need the first?
I think sometimes it's tried with just the Levodopa, and if it doesn't work too well, they'll add the Carbidopa. But notice they do go together in the medication. So like when I looked it up, the literature said Levodopa plus Carbidopa is like the standard treatment. That's like the mainstay. So it's pretty common. So Carbidopa allows it to get into the brain. The problem is it also causes another symptom, which is called dyskinesia. So another one of these words. Dys means abnormal, kinesia again means movement, dyskinesia means abnormal, uncontrolled movements. So this is the kind of thing that a lot of people associate with Parkinson's, where they're kind of moving out to here. I've seen Michael J. Fox do that. Some people think that that's a symptom of Parkinson's disease. It's actually a symptom of the medication. It's a side effect. So you kind of can't win for losing here. The good news is most patients who are newly put on the Levodopa don't get that initially. So this graph took me a while to understand. I had to kind of stare at it for a while. The squiggly line is over the course of a day. You take the medication, the Levodopa plus the Carbidopa, and you get into this therapeutic window that we call on time, where it's working well and the symptoms of Parkinson's disease are decreased. And then it starts to wear off and you get into off time, where it's not working so well. At that point you take more Levodopa, it starts to work again. However, over the course of years, what happens is that bottom ramp, that dark blue line, that means that the amount of Levodopa that you need in order to get relief from the symptoms increases, right? Whereas the ramp on the top, the light blue line or the gray line, that means that the amount of Levodopa that you take that causes the dyskinesia decreases. So as the symptoms get worse, you need more and more of it to get the same effect, and yet at the same time, the dyskinesia is getting worse and worse. Eventually, these two lines will meet in the middle, and any amount of Levodopa that you take will cause the dyskinesia. That's a lot to take in. But basically it means as the symptoms progress, it's going to be more and more difficult to treat with the medication. The good news is this is over the course of, I think, 4 to 7 years this is supposed to be. So most people do get a good effect with the medication for a long time. So far, so good? All right. Yes, ma'am.
What's the average age that this starts to show?
I think the actual average is around 60 or a little bit older than 60, but it can really present at any time,
Right.
over the lifespan,
Right.
including somebody my age. Yep. Most people are over the age of 60 though. So let's say that you've had a medication for a while and the dyskinesia symptom from it is getting worse and worse, it's getting harder to control. There is a backup plan, and that is called deep brain stimulation. Don't ask me how this works because I do not understand it. And I tried looking it up and the internet was not very forthcoming about it. What they essentially do is they implant this needle-looking thing that goes through the brain into the subthalamus, and then they use an electrical current to modulate the symptoms, to reduce the symptoms of Parkinson's. The thing about that is it isn't increasing dopamine, it's not increasing the production or the synthesis of dopamine in any way, so it's kind of just a band-aid solution, much like the Levodopa medication, which means over the course of time, as the disease progresses, this is going to get less and less effective. But it is effective for about 5 years. So any treatment at this time, unfortunately, is just kind of that band-aid effect. It's not truly treating the source of it. Once a neuron in the brain is decayed, you can't ever get it back, and that's kind of the challenge. So here's where kind of we come in as physical therapists. How can we manage it with diet and exercise? So I did find this study. This is called The Proper Diet and Regular Physical Activity Slow Down the Development of Parkinson's Disease. So that's promising. As far as diet goes, there's no one diet that's agreed upon as being the best for a patient with PD. However, a couple things that might be good ideas. Dehydration makes the symptoms worse, so drink plenty of water. Vitamin D deficiency makes the symptoms worse, so go out in the sun, get some more of that. You could talk to your doctor about it. If you are vitamin D deficient, you can get a supplement. And then eat a balanced diet with plenty of proteins, carbs, fats, vitamins, minerals, fiber, basically all the things. Excuse me. You get fiber from fruits and vegetables. Like we talked about before, constipation is a symptom of Parkinson's disease, so eating your fruits and veggies will help with that symptom. Take notice of the water. Any questions at this point? Okay. So let's get to exercise, and that's what physical therapists and physical therapist assistants specialize in. So, like we talked about, lack of strength and lack of muscular coordination are the main symptoms of Parkinson's. So because of that, we can treat it with increasing strength and increasing muscular coordination. That helps solve the problem. But even better than that, notice from the study it says, it has been found that in Parkinson's disease, exercise stimulates dopamine synthesis in the remaining dopaminergic cells and thus reduces symptoms. So even though we can't restore the neurons that produce dopamine, we can actually make them work more efficiently with exercise. So that's very promising. Some commonly recommended forms of exercise are dancing, resistance training, that means lifting weights, aerobic exercise, so walking or cycling. Swimming is great, Tai Chi is wonderful, yoga, golf, or just whatever you enjoy doing that gets you moving. One common denominator with all of these is, notice they all involve coordinated complex movements, especially with your arms and legs. Again, you're losing coordination as time goes by with PD. So if you do sports that use those muscles, you're going to retain the coordination longer, and that's going to make you less of a risk for falling. Cool therapy that I was researching is called LSVT big. So like I mentioned before, Parkinson's patients will do miniaturized versions of movements and perceive them to be normal size. So what they do with LSVT big is they train patients to do larger versions of movements. And then that resets the brain so that they can do the movements normally. So even in terms of functional things like, let's say, putting on a sock, a Parkinson's patient might put on a sock like that, it's too small. With LSVT big, we'll train them to do like this, and then once they've learned that, it's easier to put a sock on the normal way, or tie shoes, or cook, or walk, or whatever the case may be. So that's pretty cool. Rocksteady Boxing. So this is a nationwide program. It uses non-contact boxing training to treat Parkinson's symptoms. As you can see from the picture, this is from their website. They do have elderly patients doing this. So a quote that I like from their site says, "Boxers conditioned for optimal agility, speed, muscular endurance, accuracy, hand-eye coordination, footwork, and overall strength to defend against and overcome opponents. At Rocksteady Boxing, Parkinson's disease is the opponent." So all those things that they list there, those are all what we would do with therapy for Parkinson's, and it's exactly what they do in boxing. And they do have a facility for this in Greensboro, so you could look into that if you wanted to. This guy I thought was pretty cool. His name is Jimmy Choi. He was diagnosed with the young onset Parkinson's disease at 27 years old. He's now 46. He let the disease kind of get out of control. He gained a lot of weight and became obese. And at one day he was carrying his young toddler son, and they both fell down the stairs in their house. Thankfully, neither of them was really hurt. But he decided at that moment that he needed to take control of his condition and take responsibility for it. So he started to exercise, do training, he talked to therapists, got in better and better shape, and since then he's run over 100 half marathons, 15 full marathons, an ultra marathon, and he's competed on a show called American Ninja Warrior, where participants have to make their way through a very difficult obstacle course, which you can see there. So I watched a video of him. He's pretty cool. You can see he's got the tremors, he's got the symptoms, but he's got it under control. He's so physically fit and coordinated that he was able to do this show, which is pretty amazing. He's 46 years old now. So we're going to go into some exercises that you can all do on your own. Any questions before we do that? Okay. So I put a few in here. This is a home exercise program that you can all take with you, and it's all either sitting down in a chair or on your bed. I want you guys to be safe, so I didn't put any standing exercises in here. If you ever did that, I want you to do it with someone around to watch you. But first thing is seated ankle pumps, so you can all go ahead and try this while you're there. Go ahead and point your toes toward the ceiling, and then lift your heels off the ground, and then go back and forth between the two, just like that. Perfect. You can do that 30 times. That's going to help increase your circulation in your body. That's going to increase the strength in your lower legs, which will help you to walk and decrease your fall risk. Seated knee extension. You can all try this as well while you're sitting there. Go ahead and just kick your foot up like that. And then do the opposite foot. And go back and forth between your two legs. That's going to strengthen the muscles around your knee. Again, that's going to increase your ability to walk. It's going to increase your endurance, help you to stay upright. And I recommend doing all these in a slow and controlled manner. So don't just rush through the kicks, but take your time, control the movement. Seated marches. Pretend you're in a marching band. Move your knees up like that. You can do this seated as well. Alternate sides. Moving on to some stuff you can do in the bed. Seated, or rather sideline hip extension. Lie in the bed. Take the leg that's on top. You're going to be on your side, and you're going to, I'll show you. You're going to kick your leg behind you in the bed, just like that. Sideline hip abduction, just like before, but you're going to bring the foot straight up, away from you. So it's going to look like this, but in the bed. And lastly, bridges. This is the hardest one maybe. You're going to lay there, bend your knees, and you're going to bring your behind off the bed. Seems difficult, but I think most of you can do it. Bring your behind up, and then lower it back down. Do that 30 times. So, one more. Double knee to chest. With this one, you're going to bend the knees and bring them off the bed and bring them to your chest, just like it says. So that's the presentation. Any questions? Okay. Well, Morgan and I will be around for a few minutes if you guys think of anything. Thank you so much for coming. That's all I have for you. And I hope you have a great day. Yes, ma'am.
I wanted to find out if